and welcome. I'm Jeunesse Castonguay, VP at Clarius. We're excited to see so many of you join us here today for the live webinar, Using Ultrasound for Safer Injections of the Lower Face. Backed by popular demand, the fabulous Dr. Stephen Weiner will be presenting best practices shortly for using ultrasound to safely inject cosmetic fillers in the deep piriform space and jawline. Since vascular anatomy is inherently variable, safe zones for cosmetic fillers really don't exist. Using video footage from recent client procedures, Dr. Weiner will share step-by-step instructions for using wireless ultrasound to map the angular and facial arteries to avoid filler complications and deliver consistent results. We will also see some live scanning with the newly released Clarius L20 HD3 following Dr. Weiner's presentation. Before welcoming your webinar host, I'd like to welcome all of you. You're among over 1,100 plastic surgeons, nurses, physician assistants, and medical aesthetic clinicians who registered for today's popular event. Thanks for joining us from all corners of the world. It's now my pleasure to introduce you to Dr. Oran Frankel, your host for today's event. Dr. Frankel is trained in emergency medicine in California, has been using point-of-care ultrasound his entire career, and is a passionate POCUS educator. He now practices in a busy academic teaching hospital in Vancouver as an emergency physician. Dr. Frankel also serves as chairman of our Clarius Medical Advisory Board. Welcome, Dr. Frankel.
Thanks, Jeunesse. It's good to be here, and welcome back, Dr. Weiner. Before we jump in, I just want to set the stage for some of the research we did in setting up our discussion. We've done a few of these webinars already and covered some of the topics previously, but a few are really specific to today's talk. Kind of setting the background is really why we're here talking about using ultrasound. We know that the use of dermal fillers for soft tissue augmentation has become an integral part of aesthetic practices. But even in the hands of the most experienced injectors, adverse effects can and do occur. And these can range from mild bruising to severe injection necrosis with a vascular occlusion. And this emphasizes the need to detect impending necrosis after injection of dermal filler, especially with high hyaluronic acid fillers, and to be able to know at the time of injection when something has gone wrong. We know that early ultrasound can really help improve the outcome. To improve the outcome after a vascular adverse event, duplex ultrasound can be used to detect where the hyaluronic acid filler went and where, if it is causing an occlusion, where it's caused an intra-arterial obstruction. And if treated in time with ultrasound guidance, a single treatment of ultrasound guided injection of hyaluronidase into the filler deposit can prevent downstream skin necrosis. So this implies the use of duplex ultrasound may become an integral part of preventing and treating injection adverse events. In kind of a broader review, in this recent review, which highlighted that in addition to specifically targeting and treating the complications, Doppler ultrasound really can find its time to shine in studying the anatomy of the patient to prevent these intravascular injections in the first place. And these authors who wrote the review are predicting that with the way that we're seeing point of care ultrasound spread across clinical practices, that in aesthetics, it won't be any different. And that duplex ultrasound at the point of care will become standard equipment in the offices of cosmetic doctors soon enough. Kind of highlighting this, we wanted to review a poll that we did on a prior webinar, which we know that all of you are across the world and coming from various areas of practice. And we posed, what challenges do you find concerning when performing dermal fillers? And not surprisingly, there was a lot of agreement here that despite a keen knowledge of anatomy, vascular structures have a high degree of variability. And that's one of the key points that we're going to see Dr. Weiner really go deep on, is being able to visualize specific anatomic variations and being able to detect later, when is a bruise just a bruise, or is it a sign of vascular occlusion? And why isn't my patient responding to hyaluronidase? Maybe we have the wrong diagnosis. And being able to clarify additional diagnoses, like if it's really fat prolapse or if it's problems related to filler, and identifying where the angular artery was and the superficial temporal artery. So before we jump in, we're going to put a new poll to you that kind of flips it and says, what do you see as the key benefits in using ultrasound to bring to facial aesthetics? Please answer all of them because we know that you're across the board, and it really shows that everyone is experiencing not only the same challenges, but we want to see where you see these benefits in your practice and what brings you here to today's webinar. Is it to improve your understanding of facial anatomy, to identify the precise location of vascular structures, reduce the risk of complications, and improve the safety of your procedures, to provide rapid and effective response to complications should they occur, or to increase your patient's confidence and generate additional referrals? We'll give it a couple seconds here. And let's close out this poll. And really across the board, this is one of our broadest results here that we've seen, but maybe most folks really looking and in the right place to see and benefit identification of precise location, and then to reduce the risk of complications. Well, this is the ideal webinar with the ideal speaker to bring that kind of knowledge to you today is Dr. Weiner, who we're so happy to bring back. A board certified head, neck, and facial plastic surgeon who, after graduating from UCLA, he completed medical school at the University of Michigan. He interned and spent his residency at Johns Hopkins Hospital, where he became an instructor for 2 years in the Department of Head and Neck Surgery and Facial Plastic Surgery. Dr. Weiner established his private practice in Thomasville, Georgia, with great success for 10 years before he envisioned the future of cosmetic procedures as non-surgical. And in 2005, he laid down his scalpel, concentrating 100% of his efforts in non-invasive and minimally invasive cosmetic procedures by founding the Aesthetic Clinique. Dr. Weiner maintains an extensive lecturing and teaching schedule. He's a frequent speaker at international conferences across the world. Dr. Weiner is one of the top physician trainers for Galderma and participates in their Train the Trainer, where he additionally helps educate Galderma trainers themselves. He's been invited to several advisory boards, including Galderma, Revance, Lutronic, Suniva, and Allergan. His areas of expertise are acne scar revision, fillers using blunt microcannulas, and as we'll learn, ultrasound of the face, as well as RF microneedling. Dr. Weiner, over to you.
Hey, thank you, Oran and Janez and Clarius for inviting me back. And I'm happy to discuss my experience using ultrasound in the piriform space, the deep piriform space. And then I'm going to throw in a little bit about the jawline. As you know, I'm the rejuvenator, so I had to throw that in a little bit. So let's move on here. So let's first back up and how I use the ultrasound in my practice. So I do vascular mapping, and I'll show you what it is in the piriform. It means basically looking for the vessels for its location and its depth, because we all know that vascular anatomy is inherently variable. I also look for fillers. People that have had fillers before, they don't really know what they've had sometimes, or they don't know where it is. So I can actually find the filler using the ultrasound. I also use it as a teaching tool, as well as a precision tool to tell me where the cannula or the needle is, so I can place it in the precise right plane along the periosteum, above or below the SMAS, for instance. I also do exact guided injections, particularly when I'm trying to dissolve filler using hyaluronidase. And when there is a vascular occlusion, which I'm going to show you a couple of those, I'm able to diagnose that occlusion and pinpoint the exact area that I need to inject to reverse that occlusion. So let's start with the deep piriform space. The aging process leads to deepening of the midface, and that's caused by a combination of retrusion and rotation of the maxilla. So it goes backward and rotates inward. Other factors, obviously, are fat pads. They deflate and descend. The superficial fat pads tend to descend, whereas the deep fat pads tend to deflate. So a popular correction of the midface is a deep supraperiosteal injection of the deep piriform space. So I'm very happy to show you this paper that was written by my colleague, Chris Zurich, who I do monthly anatomy labs with. And he was the first to really describe that deep piriform space well. So most importantly, what we're worried about when we're doing these deep piriform space injections is that angular artery. And I'm going to show you that it's variable. But in general, it lies superficial to the space. It's bounded laterally by the deep medial cheek fat, which is right here. Here's the angular artery running superficial to it. The space is in blue here. And then it's superficially bounded by the SMAS. which is the lip elevator, which is the levator labii superioris, which is right here. Inferiorly, there's a hammock, and that's the depressor septi nasi. That's right here. This space goes all the way up to the tear trough. So even though you're injecting paranasally, you can enhance the whole midface up to the tear trough with this technique. Also, there's a branch of the infraorbital nerve that traverses through this space. So oftentimes, if you're wanting to do lip filler at the same time, it's highly recommended that you do this procedure first, so you end up with superior lip numbness and makes the procedure more comfortable. So this is an anatomic, this is a cadaver dissection showing you the deep piriform space right here. And here's the deep medial fat pad. And the angular artery runs between these two and then superficial to that deep piriform space. So as it was described in the paper, the angular artery courses in the roof of the rhisto space, which is a deep piriform space, within a septum between the space and the deep medial cheek fat. So what is the usual angular artery course? So after the facial artery gives off the superior labial artery, that artery now has changed its name to the angular artery. That might not be exactly what everyone was accustomed to, but that is the current terminology for angular artery. Also, it will typically run medial to the nasolabial fold, and that is based on Dr. Sirich's unpublished data. There's one paper that says it runs lateral to the fold, but in our anatomic dissections, they mostly run medial to the nasolabial fold. When it comes close to the nose in the medial 1/3, it crosses laterally, and usually at depth of 4 or 5 millimeters. And it usually runs in the SMAS until it gets by the alar rim. So this was an interesting paper I recently read, and there was a variation of the facial artery, but in describing this, they went through several papers to review the data on the different courses of the facial and angular artery. I only picked 3. I think they went through at least 8 or 9 of them, but you can see there's high variation between those papers as well. So not only is there variation within the paper, but there's variation between these papers. But the bottom line is approximately 30% of the time, there isn't an angular artery overlying the deep piriform space. You see these 3, it is overlying that deep piriform space, but in these 3, it is not. So 30% is a good figure. So you really have an easy shot in 30% of cases, but you don't know what is sitting there in front of you. So this paper also confirms that they used ultrasound. The other ones was anatomic dissections. They used ultrasound and looked at the angular artery. And what they found was there was no artery in the nasolabial fold and piriform in 30% of the cases. But in 4% of the cases, the angular artery was submuscular. That means below that SMAS layer. So it could, and in another paper I saw, 1 to 2% of the time, it runs along the periosteum. So 30% of the time, there's no artery. 1 to 2% of the time, it's in the exact spot that you want to inject. So how do you know that? Well, you need to use your ultrasound to determine that. Also, this was another interesting paper, and it showed that in 90% of the cases, there's 1 angular artery in the nasolabial fold. But in 9% of the cases, there's 2. And in 1% of the time, there's 3. It tends to have more branches in females than in males. And Dr. Cotofana was part of that paper, which he's part of a lot of these papers these days. So many will argue, well, if I aspirate and it's negative, well, I'm home free. Well, that's really not the case. And I'm one of those believers that aspiration isn't going to give you the end all and be all, whether there's an artery there or not. In fact, Dr. Goodman went out and he's an advocate against the aspiration. And he says neither a positive nor a negative aspiration is a procedure that should be relied upon. His argument is that when you're aspirating, you have to keep the needle in the exact same spot that you are going to inject, and that's nearly impossible. Also, as you can tell by the illustration on the right side, it's possible that you can get a negative aspiration by pinching off the vessel with the needle and still inject inside the vessel. So I just wanted to show you one of my cases. I'm going to go through it in depth in a second, but this is what filler looks like in the deep piriform space. So this is the periosteum. So the deepest part of the structures, the image is going to be the bone, which is right here. The top part of the image is going to be the epidermis. And so the deep supraperiosteal injections along the periosteum. And you can see that the filler is deep to one of the angular arteries. There's a deeper one here that it's superficial to. So this tended to be a great injection with a great correction. So this is an interesting case. This is actually my wife. And I want to show you here that she has an angular artery that's in its typical position on her left side. And I'm going to just show you, and I'm going to measure it, and it's right here. Okay, so here's the bone. And it's basically halfway between the skin and the bone. And, typical position, 3.5, 4 millimeters deep. And there's about 3.5 millimeters or 4 millimeters deep to that. So that's an easy shot. But on the opposite side of her face, you're going to see something entirely different. You're going to see that she actually has two angular arteries, and one of them is along the periosteum. So there's the typical one that's in the mid portion between the skin and the periosteum, but over here is a deep one. Okay, so this is someone you have to be extremely careful with these deep injections, and you wouldn't know that she has two or she has one that is deep if you didn't have your ultrasound. So now I'm just going to measure the depth of this one, and you will see that there's probably about 1 millimeter, less than a millimeter between that artery and the periosteum. So it's quite a difficult injection in this patient. You might consider a more superficial injection with a cannula for safety purposes in this patient. So I wanted to show you what a vascular occlusion looks like on ultrasound. And over here, you see an artery, but it's kind of discontinuous. And in the center of the artery is an HA, okay? And it's pointing to the HA product. So this is what a piriform vascular occlusion looks like, okay? Now, this isn't the same patient, but this is actually a colleague of mine who had an occlusion using calcium hydroxyapatite. And as you know, that's not dissolvable. That's not sensitive to hyaluronidase, although it is recommended because it does do a dispersion and it does help with the carrier, but still she didn't have many options. So she eventually did extremely well, despite the way it looks, with wound care and so forth. You never know that she actually had a vascular occlusion or necrosis of her skin. But that's someone who got kind of lucky and was actually, she's an injector, so she knew how to do wound care properly. But that's what we're trying to avoid. So what I'm showing you here is visualization of the angular artery in the piriform. I like to use this is the HD3. I like to use it in a fashion like that because that's cross-sectional, that's out of plane, that's going to give me the most area to look for the vessel. And as I showed you before, so here's the vessel. I'm going to measure it, and there's plenty of room below that vessel for a safe injection. And what we're doing here is we're going paranasally, and we're going straight down. And actually, she's going to do a little aspiration. She wanted to, I didn't insist, but she wanted to do a little aspiration. And she injected straight down onto the periosteum. And so what you're going to see here is a bolus of HA product along the periosteum. And in a second, you're going to see the artery that is visible and completely intact. And you can confirm to the patient that I saw everything, and it gives the patient confidence that the procedure was done safely. So there's the artery completely intact with the HA product below it. So I'll do a little bit about jawlines because I love jawlines, and we're talking about the lower face. And let's talk about the importance of jawlines. So I consider the jawline the most important aesthetic unit in the male face. And in the female, it's probably number 3 behind cheeks and lips. Obviously, jowling, and if you lost the shadow between the neck and the face, that's associated with aging and unattractiveness. Strong jawlines are associated with confidence, honesty, and authority. There was a study done on all the Fortune 500 CEOs, and 95% of them had strong jawlines. A strong jawline is also associated with high testosterone levels. And for females, that means they're better mates and they're more fertile. However, high testosterone levels and strong jawlines are associated with infidelity as well in males. So there's several differences between the male and female, and you have to abide by these differences or something looks weird. And I've seen some weird jawlines on Instagram. So the biggest thing is the bigonial width, which is the width between the gonial angles and the bizygomatic width. So in males, as you can see on this side, the bigonial width is basically equal to the bizygomatic width. On the females, the bigonial width is going to be less because you want a more V-shaped or heart-shaped appearance. Keep in mind that if you're going to enhance the lateral aspects of the zygoma, that might throw out the proportions in the male, and you need to enhance the jaw as well to keep it in proportion. So now let's go to gonial angle. Gonial angle is the angle between the ascending ramus and the body of the mandible right here. So the gonial angle in a female is 120 to 140, and for the male, it's 100 to 120. So it's more sharper angle in the male. This is most important and often forgotten. The level of the gonial angle. In the male, the gonial angle should be at the level of the oral commissure. In the female, it actually should be above the lip, because most of the height of the male's jaw is the ascending ramus, and most of the height of the female jaw is the body. So the shape of the jawline in the male, it should be very structured. It should be very straight and angulated. In the female, actually, it should be gently curved up. So it's not quite as straight and structured as the male. And then the chin. So Kendall's chin is a little bit off here, but in general, you should have 1 point of prominence in the female chin, and you should have 2 in the male. The width of the male chin should be about the width of the mouth, and the width of the chin in the female should be about the width of the nose. So there's several planes to inject in the jawline. You can do a superficial injection, which is a plane that I love to do. And you're injecting in the superficial plat, also called the supraplatysmal plane. It's safe because the arteries are deep, and you get a good correction per cc of filler. However, there's others that like to use a needle, and they like to go deep onto the periosteum. And the filler is going to be a little less noticeable. But you have to be a little bit worried when you're going deeply about the placement of the filler and the facial artery and vein. So I'm going to use ultrasound to determine the placement of the artery and vein, and then I'm going to inject posterior to it. And oftentimes you'll do a combination, superficial and deep injections. So right here, I'm looking at the facial artery and vein in the antegonial notch, okay? Actually, I'm just looking at the artery at this point. We're going to look at the artery and vein in a second. So I'm showing the exact position of the artery, and then I can mark that with a pen and make sure that I'm injecting posterior to that. I'm going to be injecting deep onto the periosteum. Again, it's probably unnecessary to do the aspiration. And then I'm going to confirm the placement using my ultrasound as to where the filler is. So when you inject onto the periosteum in the mandible, some of the filler does go within the masseter, and that's okay, because there's a little bit of retrograde flow when you're injecting onto the periosteum in this area. Also, the movement of the masseter is going to move that filler around. But the filler is perfectly fine, and we confirmed its placement, and we can move on.
Are you scanning every patient, Dr. Weiner, both in the jawline and the piriform space?
I think that it's very important when you're doing the deep piriform space to scan the patient. When you're doing the jaw, you can usually figure it out by palpating the antegonial notch, and it's a pretty safe injection near the gonial angle. So I scan patients when there's a complication, when there's filler that I don't know what's going on. And when I'm injecting into critical structures like the deep piriform, the temple, the nose, and potentially the tear trough area.
Mm-hmm.
So this is the way you can contact me. I do run a course, sonosthetics, that you can look at my website for the training opportunities. So now I think we're turning it over to Shelley, and she's going to do a live demonstration of visualization of the angular artery as well as the facial artery and vein.
Thanks, Dr. Weiner, and thanks, Saran. That was great. I always learn so much, and what amazes me is that we can, even though those vessels look big on the screen that you're imaging on, how tiny they are, and I have to say, you make it look easy. So, when I began my career in diagnostic ultrasound just a few years ago, I never dreamed that we'd be imaging in the realm of the 20 megahertz range. So, it's pretty amazing. And the other amazing thing is that we're doing this with the wireless scanner now. So we've come a long way. So we are lucky enough to have a model here today, and I'm going to try and mimic Dr. Weiner's technique to image the facial artery and then the angular artery up in the nasolabial fold.
Yeah, these arteries are sometimes sub 1 millimeter. So it's amazing the clarity we get with this Clarius.
I'm just going to turn the color Doppler on here.
Long axis.
Yeah.
Well, there you go. Well, that's obviously the artery,
Yeah.
right?
That's the artery for sure. I like to image these structures with power Doppler as well, because it's less angle dependent for me, and it's still very, very sensitive to flow. And I'm in the aesthetics preset here, which is a new preset that's offered along with dermatology and plastic surgery presets. It's part of the advanced plastic surgery app that's on the 9.0 app.
Yeah, so power Doppler is going to give a little more sensitivity to visualizing vessels. If you're having a hard time finding one,
Yeah.
power Dopplers.
Now, there's another new feature on this app that I'm going to show you, and it's called it's called Vessel Depth AI, the AI standing for artificial intelligence. And I'm just going to go into the mode settings here and turn on this app. It's a vessel tracking technology that's actually going to show us in the upper right-hand corner the depth of that vessel without actually having to do a measurement. So this is going to give you the ability to kind of do this, determine your vessel depth kind of hands-free. I've frozen the image here just because it's hard to stay on it while I'm reaching for the iPad here. But you know, again, it would be really nice if you don't have to touch the iPad while you're scanning. I've launched the power Doppler and the color Doppler, and with the new aesthetics feature, we've also kind of tweaked the color Doppler as well as the 2D settings, just so that there's less noise and less artifact when you're moving around, less flash. So just a little bit easier to work with these tiny, tiny little vessels. So I'm just going to head up to the region of the angular artery here. And again, I think I see the vessel in the middle, but I'm going to turn on my color Doppler again. And then there's our vessel there. So again, fairly obvious. If I want to go into the power Doppler and use the vessel depth AI, I can do that. And it's displaying that depth in real time. So it's a really nice new feature.
Yeah, that's awesome.
Oh, yeah, there you get it, cross section. And so your strategy for injection here, Dr. Weiner, is identify, you know, what the anatomical variant is in each particular patient and locate the artery, its depth, and then you know safely where to inject and how deep.
Yeah, that's right. So you could argue, well, can I do it under guidance? If I were to do that, I'd have to use a much longer needle and I'd have to traverse a lot more tissue to visualize it. So you could do that as well, do it under direct guidance, but you probably need, you need about a 1.5 inch needle to do that, because when you're coming in from the side, you want to visualize it. But I feel that if I've identified the artery and I'm down on the periosteum, I'm fairly safe because I've already identified the location of the vessel.
Right, you've got space here between the artery and the periosteum, so you know when you hit the bone, you're good.
Exactly.
Yeah.
The other thing is that when you're doing it under direct visualization, you don't get the sense of what the correction is because your ultrasound is on top of it. When you're doing it without the ultrasound, after you've identified the correct depths and so forth, you can actually visualize the correction and know when to stop and when is enough.
Seems like doing live guidance would be better for trying to correct an occlusion. You know, if you really need to kind of strategize and target this really micro location, it seems like you have a broader window of where to put the filler rather than where to dissolve a filler if you need to.
Right. Or it could be a starting point too. Like, okay, I've identified where the artery, where the needle is. It's on the area or in the plane I want to inject. And now I can remove the ultrasound and do a small bolus. If you're doing movements with the cannula or needle, you can't actually do that with the ultrasound because the window of visualization with an ultrasound is approximately the width of a credit card, the side of a credit card. So you don't have a lot of movement to stay in that plane.
That's very true. I think it's something that a lot of users don't kind of appreciate is that the width of that beam is a sub-millimeter level. So yeah, you don't have a lot of room on either side. And any little movement is going to make a big difference.
Exactly. Did you want to try the power wave Doppler? Or?
Sure. One thing we were talking about just before we started the webinar was the use of pulse Doppler to identify vessels or to determine whether it's an artery or a vein. Now, pulse Doppler is typically used to get velocity information about a vessel, but and it's a little bit more of an advanced technique, but I'll show you how it works on the system. We can go into the pulse Doppler mode, and I'm just going to set my little crosshairs right on the vessel. And then we'll actually get a sound, but you can clearly see that the spectrum here is showing a pulsation. So we're definitely in an artery there. If it was a vein, it would be just more of a, not even phasic, just kind of a flat, kind of straighter line across. So that's just another option you have for distinguishing an artery from a vein.
Yeah, obviously that's more advanced than most people need to know, but it's good to know that this ultrasound has that capability if you wanted advanced techniques to
Yeah,
use.
exactly. And again, in the aesthetics preset that we have, it is optimized for these small vessels. So, it'll give you the answer that you need right away without too much fussing around, as long as you got a steady hand.
Exactly. Well, thank you.
You're welcome.
Great. Thanks so much, Shelley, for demoing kind of how straightforward both the beginner and advanced techniques can be on the face. When I was learning how to use point of care ultrasound, yeah, I'm with you. Like, I never imagined I would be visualizing the angular artery, certainly, small millimeter size arteries in the face, on the carts even that we trained on. So now to see it in a handheld is pretty amazing.
Yeah, it's pretty crazy.
Yeah. So Dr. Weiner, would you agree on these kind of ways where ultrasound can really add value to your practice? I think you kind of showed us the vascular mapping, and I'm a believer that, at least in other areas of medicine, we kind of say that at this point, really ultrasound should be done before any needles are going in patients. And it's interesting that it's spreading to cosmetics too, to improve patient safety.
Yeah, we have been flying by the seat of our pants, injecting without any guidance with ultrasound up until this point. But every other specialty in medicine is using ultrasound. Okay, ER docs, OB-GYN, obviously, and anesthesiologists, pain control. Even plastic surgeons are starting to use it, looking at breast and rupture of the capsule and so forth. It's high time that we need to adopt ultrasound in our practice. I think for optimal patient safety, for optimal results. Also, what if there is a complication? I'm getting calls weekly about complications from filler, particularly vascular occlusions. I'm not going to be able to fly, or the patient aren't able to fly all the time to get it resolved from me with ultrasound. So sometimes I guide them, but basically you should be able to take care of these problems with an ultrasound at your practice. Think about the cost associated with dozens and dozens of vials of Hylenex. They far are going to be more expensive than the ultrasound, and trying to mitigate the problem with the ultrasound rather than the cost of all those vials. You can usually take care of complication with ultrasound with a couple vials.
Have you noticed that your patients are more confident too? Like after the procedure, showing them, it's all good, the artery's still there, and
yeah. So I think it's a great tool. It's going to bring patients in too. So don't look at it as a lost revenue source. It's not. It's actually going to bring patients to you. You're going to have patients that want the best, that the state of the art, and then you're going to get some referrals too from other injectors that are having problems. So the patients are going to love you because look, you can show them, this is your filler. I put it in the exact right spot. This is where I wanted it to go. And everything looks normal, and the vascular structures look normal. So the patients love it as well.
Yeah, I imagine it really conveys that you really care about your patients, right? You're kind of going the extra mile, and they feel pretty kind of high class and special. They have a special technology to image them.
Well, yeah, I mean, I'm all about safety. That's my number one, number two, number three most important things. So anatomy courses, ultrasound, and cannulas. I know there's some people who don't believe in them, but I do believe that they are safer, and there's a couple of papers who suggest that. But you have to use needles in certain cases, and particularly in those cases, ultrasound will help guide you to a safer injection.
Well, thanks so much, Dr. Weiner. We still have time. Please use the Q&A, which I see a lot of you are already filling your questions here. We'll have some time here to get to that. First, we're going to hand it over to Janez, and we will get to your questions in a moment.
Dr. Weiner, thank you so much for your best practices that you shared with us today. Here's another quote from Dr. Werner on the other side of the world, who's also quite enthusiastic about using ultrasound in her cosmetic practice, and echoes a lot of the same things that you said today in your presentation. So let's just look at this quote for a moment here. Patients are very excited and amazed when they use ultrasound. It impresses them when we can show them what we're doing, where the vessels are, and how the filler is injected. It also makes patients feel safer, and they feel they're in a high-end clinic. And I think those were all words that were echoed with your patient D, whose procedure you shared with us today when we got to interview her following the opportunity to film your procedure. And if you go to our website, you'll see the interview with Dr. Weiner's patient D and how enthusiastic she is about the use of ultrasound for her practice, for her procedures, and how much safer she feels about getting her injections as well. So next, I would like to also thank Dr. Frankel for your insights, and thank you, Shelley, for the fabulous live scanning. You make it look so easy as well. Just before we open up the floor to our live Q&A session with our guest speaker, here's a quick poll question for you. We'd like to help everyone continue their journey in bringing ultrasound to their aesthetic practice. So please do complete this poll if you'd like any additional information. Clarius scanners are available worldwide in over 90 countries. And so price does differ, as does availability. So if you'd like to get quote and learn about availability in your region, please go ahead and select that. If you'd like to opt to speak to one of our experts about the advantages of ultrasound for your aesthetic practice, we can certainly set up a call with you. We can discuss scanner feature options. You can book a live demo where you can see it in action, live scanning on a one-on-one basis where you can ask questions and have it be more interactive. And you can also watch more tutorials. Dr. Weiner has been so fabulous to invite us to his clinic for a variety of different patient demonstrations. And so we have a number of video tutorials available. If you select that option, we'll be sure to send them to you. Just before starting our live Q&A session, and while you answer this poll question, I'd like to take a minute to introduce you to the new Clarius L20 HD3, the world's only high-frequency ultrasound in a 20 megahertz wireless scanner. Now 30% smaller and lighter with an integrated battery, and it's available in the USA and other select countries. Our new advanced plastic surgery package includes AI-powered features to automate workflows, like the new vessel depth AI, which Shelley demonstrated for us today. Since the 80s, ultrasound has been a recognized gold standard among plastic surgeons, but systems were costly and complex. Today, Clarius Ultrasound has changed the game in facial aesthetics. Miniaturization and innovation with handheld units means high-definition imaging is now easy and affordable, with image quality that rivals traditional systems at a fraction of the cost, representing savings of well over 80% over traditional systems. The Clarius L20 HD3 is the only handheld ultrasound with ultra-high frequency to 20 megahertz for exceptional superficial imaging to 4 centimeters for facial aesthetics. It's the leading choice for plastic surgeons, dermatologists, nurse practitioners, PAs, and medical estheticians. With this best-in-class high-definition imaging of the skin, vessels, muscles, and fascia, you'll gain confidence in your needle placement, easily characterize and evaluate fillers, and accurately treat complications, improving patient safety with consistent treatment outcomes. The secret lies in the technology, with each scanner featuring 8 beamformers, 192 elements, and artificial intelligence that together deliver the crystal clear image quality only found in traditional systems. Artificial intelligence replaces complex knobs and buttons, making ultrasound imaging fast and easy to use. Clarius is also wireless, freeing up space with zero footprint. It's fully immersible and so much faster to clean and disinfect as well. Only Clarius delivers linear wireless scanners with an ecosystem that includes a free app for your iOS or Android devices with free updates. Clarius Cloud is available to capture and manage your exams from anywhere. We also offer Clarius classroom videos with experts like Dr. Weiner, and onboarding live one-on-one with our Clarius clinicians to build your ultrasound scanning skills. Now we're just going to close off the poll. And if we didn't get a chance for you to ask questions during this poll, don't worry, you can ask for information in our closing survey. I'd like to now welcome back Dr. Weiner and Dr. Frankel for our live Q&A session. I do want to let everyone know that a recording of today's session, as well as a PDF copy of the presentation, will be emailed to you in the coming days. Please use the questions icon in the menu bar to ask your questions of our great doctors. Dr. Frankel, if you can moderate, please.
Yeah, happy to. A lot of questions. So we're going to do our best to get through as many of these as we can. So starting at the top, what about, this is actually a question I had too, about parotid injury. So I'm wondering, when am I going to see these patients in emergency department? Is it a thing, parotid injury, like going too deep, injecting too deep, and then would the ultrasound help prevent it if it was a thing?
Yeah, the parotid injuries are probably more frequent than we actually know. We probably get away with it sometimes. When you're injecting in the preauricular or submalar area, which is about right here, there is a thin plane that you need to get in with your cannula. And if you get too deep, you can get below the SMAS and below the parotidomasseteric fascia and into that parotid gland. When you're injecting deep along the gonial angle area, you should be safe. You should be deep to the parotid. I would not inject along the ramus because you are more likely to get a parotid injury with those injections. So I like to inject along the gonial angle and low along the jawline and not go up the ramus. So I have seen injuries. I've seen parotiditis, which would be an inflammation of the parotid gland. I've seen salivary leaks or sialoceles, where you get a collection of fluid from rupture of the parotid duct. And I've also just seen inadvertent HA product within the capsule of the parotid that causes discomfort upon chewing. It causes irritation of that fascia. So those are all different things that could be seen on ultrasound and could be mitigated using ultrasound-guided hyaluronidase.
Can you talk a little bit, Dr. Weiner, about your patient flow and how has ultrasound impacted your patient flow, and where do you incorporate it into your patient practice? Do you have the assistant, or what does it look like when a patient comes in and they get an ultrasound assisted procedure? So
there's all types of patients. My standard injections where I'm injecting in, let's say, the prezygomatic space, tear trough, I'm usually not using ultrasound for that because those are pretty safe injections when you're using cannula. But if there's any question, you can take 5 to 10 minutes and map out the vessels. But I'm not typically doing that because I've done it so often and so frequently. But if I'm injecting temples, I'm pulling out that ultrasound. I'm looking for that superficial temporal artery. I'm looking for that deep temporal artery. I'm trying to decide if I'm going to inject deeply or superficially or both. And I kind of use the anatomy to help determine that, as well as how deep the volume loss is. If the volume loss is pretty significant, I usually like to go deeply onto the periosteum because the filler is hidden by the muscle. But I often will get patients either self-referred or referred in with filler complications, and they just don't know what's going on, or they want their filler removed. They're having problems. I had a patient come in recently who was having a lot of infection related to the filler, and she says, I need every bit of the filler removed because she was having biofilm and recurrent infections related to that. So there's all different types of fillers, complications. Obviously, vascular occlusions are only done with ultrasound at this point. But if I'm injecting other areas like the nose, which I don't do too often, you need to use the ultrasound because 20% of the time where you think the artery is laterally, it's going to be midline, and 20% of those times it's going to be along the periosteum. So around approximately 4% of the time, that artery, the dorsal nasal, is going to be midline along the periosteum. I like to know that before I inject. Chin, I want to know where that ascending submental artery is if I'm using a needle. I generally use cannula, so I don't have to use the ultrasound. So there's a lot of cases where ultrasound, let's say I have a bruise is it occlusion? Is it a bruise? It looks like swelling. There's a lot of pain. I just don't know what's going on. Pull out the ultrasound and I can rapidly determine, I can sleep much easier knowing that it's just a bruise versus an occlusion.
I imagine the patient sleeps easier too.
Exactly.
Yeah. What about another question that came up that we haven't really talked about before is what about venous injections or, injecting into a vein? We talk a lot about vascular occlusion in the arteries.
Yeah, certainly. I actually recently came on board with venous problems being actually a problem. I wasn't.
You weren't a believer before?
I wasn't necessarily a believer, but I have been involved in cases where there's been venous occlusions, and they behave a lot differently. The skin looks different, but you can still diagnose it with the ultrasound. But there was one case where the facial vein, the patient was injected deeply on the periosteum, and the facial vein was actually injected, and the whole face got congested and red. So it was a little bit different. It wasn't an occlusion where there was ischemia, but it was just an unusual presentation, and it had to be the injection of the vessel. Unfortunately, it was actually calcium hydroxyapatite. So the patient was sent for hyperbaric oxygen therapy, and there was some hyaluronidase injected to try to dilute it and disperse it as well. So it does become a problem, and ultrasound can find those just as easy as they can find arterial occlusions. Yep.
Do you ever, this is an interesting question, do you ever visualize the nerves of the face with the L20? And then is that useful information ever?
Nerves are a little bit more difficult to find with ultrasound. Now, the larger nerves on the other parts of the body are more easy to see, like the median nerve and so forth. But on the face, they're a lot smaller. So the mental nerve, you can sometimes visualize, the infraorbital nerve sometimes. They're more visible because the artery is associated with them, and I can see the artery a little more easy. So if I identify the infraorbital artery or the mental artery, I know the nerve is right next to it. Yeah, those are areas where you obviously don't want to inject in those areas. But in general, motor nerves like facial and so forth, they really don't have long-term complications. I've seen a couple praxias of those nerves, but they always come back. I have seen some long-term complications from the infraorbital nerve irritation.
I'm not sure if this is really for, I just kind of, some folks are wondering sort of beyond aesthetics use, maybe you could speak to, in the head and neck surgery world, additional applications where you saw ultrasound useful for folks.
Well, obviously, looking at parotid tumors and thyroid tumors, okay, the L20 is great to look at the thyroid. You can also look at the submandibular gland. So yeah, there's a lot of different areas you can look at that aren't, there are some people that do ultrasounds of the eye as well. So yeah, there are some applications for a head and neck surgeon that's not doing aesthetics.
Some people want to know about the deep masseter. I'm not sure. Do you calculate the depth on where to go for your injection, and do you do the injection live, like ultrasound guided, or do you just sort of do a landmark after you ultrasound it?
So there's a Korean group who have trademarked the term sonotox, and they do guided injections of the masseter using ultrasound to make sure that they get what they're getting at, Oran, is that sometimes, it's very rare, you get a little paradoxical pooching of the masseter after injection of Botox. You inject the Botox or Dysport in the masseter to relieve the tension, but sometimes you get that pooching. It's related to the toxin in the paper that I read, not getting to the superficial aspects of the masseter and only a deep, because there's a tendon that prevents the spread superficially. Now, I've heard arguments the opposite way too. So, but the paper I read, it was related to the deep injections not diffusing superficial enough, and you inject the superficial. But anyways, I haven't had that problem. I think if you're having that problem frequently, it would be a good idea to do it under ultrasound guidance. You obviously have to use a larger needle because, again, you need to do it in plane. In plane means the ultrasound foot plate is this way and the needle is in the same plane. Out of plane means you're doing it this way. Usually you get much more information if you're doing it in plane. So yeah, I mean, you could, it doesn't really take me very long to do the injections, and I haven't had complications using without ultrasound. But again, there are some people that do it.
What is the minimal difference? I know we talked especially in the piriform space about the depth of the artery and where the periosteum is. What do you use as minimum distance of safety of, you know, the delta maybe of the depth of the artery to the periosteum?
I want to have about 3 millimeters between the artery and the periosteum. Maybe I might shade it to 2.5, but anywhere less than that, I would consider redirecting the, now it's a great procedure, but if the artery is there, you can do one of two things. You can change your plane and do it superficially in the subcutaneous plane or superficial fat, or you can do, as we described, the guided injection, and you can see the vessel and you can see where the needle is, and it's not in the same area, and inject it safely.
I think we have time for one more question, and this is the classic one. How do the participants learn more? How do they become more proficient? What's the minimum number of scans they need to feel like they know what they're doing with the ultrasound probe?
Well, I can just tell you that I'm still learning. And Michelangelo, funny story is he was 84, and at 83, he said he's still learning. So, you know, you get better and better at it. You need to practice and practice. So but you also need an introductory course. I offer one, Dr. Stella offers one, and Leonie Schelke offers one. And Danny Sparkle Aesthetics also offers one. I'm doing one with her. So I think if you do a course, mine is 1 day. Dr. Leone's is 2 days, and so forth. I think that you get a really good jump start on using ultrasound, but then use it every day in your practice. And if you're not sure exactly what you're looking at, take a picture of it with your scanner and then look at it in the future, and then you learn from that. There's a couple textbooks out there, but it's mainly just getting your hands on and getting used to all the manipulation to get the optimal visualization of vessels and so forth. The vessels are the hard part, but also identifying the structures. And I do feel that a anatomy course, a cadaver course, is very useful in ultrasound as well. The other thing is kind of learn some landmarks like the SMAS. The SMAS is fairly constant throughout the face. It's going to be about 3 to 4 millimeters deep. Then the DAO is very easy to find. The deep fat pads are sometimes either the masseter, the parotid gland. So finding these landmarks then gives you a clue as to what you're looking at, what's next to them, and so forth.
Well, we are at the top of the hour. I'm going to hand it back to Janez to bring us home here.
All right.
Thank you so much. Thank you so much, Dr. Weiner. Thank you so much, Dr. Frankel. We have dozens and dozens of questions, and Dr. Weiner has kindly offered to answer questions by email in the coming days. And so we will follow up with you if we didn't get to your question during the live Q&A session. So thank you, Dr. Weiner, for your follow-up with all of the very engaged folks who joined us today. A friendly reminder that you will all receive a copy of the slides and webinar recording in the coming days, so please do keep an eye on your inbox. As well, if you could please complete our closing survey to provide your feedback, that will allow us to bring you more educational webinars like today. To conclude, a big thank you, Dr. Weiner, Dr. Frankel, and Shelley Gunther for all of your insights. And a big thank you to all of you for joining us here today. Have a wonderful day and keep scanning. Thank you so much.
Thank you. Bye-bye.
Everybody.
Thanks, everyone.